Welcome to another exciting episode of Inside Humani Medicine. I'm your host, Henry Ford, the Dean and Chief Academic Officer of the University of Miami Miller School of Medicine. Today, I'm delighted to welcome to the studio Dr. Juan Umaña, an internationally renowned cardiothoracic surgeon, innovator, and educator who has spent his career pushing the boundaries of cardiothoracic surgery. Born and raised in Colombia, Dr. Umaña's remarkable journey has taken him to some of the world's leading medical institutions. During that illustrious medical career, he has co-developed the world's first transcatheter mitral valve repair device. He's helped elevate an entire nation's cardiac care system, and he has mentored and trained hundreds of surgeons. And now, as Chief of Cardiothoracic Surgery at UHealth, the University of Miami Health System, and the Miller School of Medicine, Dr. Umaña is leading a new era of innovation in cardiovascular surgery and shaping the next generation of surgeons. Dr. Umaña, welcome to the program.
Thank you. Ford, it's a pleasure to be here.
Wonderful. Let's start from the beginning. Tell us a little bit about your upbringing in Colombia and what prompted you to pursue a career in medicine.
Well, it's a long story, but my whole family is a family of engineers. So I always thought I wanted to be an engineer. But my mother was more of an artist and a social worker. Really, she was into social endeavors, and I think that is what really stayed with me and marked me. So I shifted from civil engineering into biomedical engineering, and then discovered that what I actually enjoy most is the contact with people and helping people, but really hands-on, and through social work, that was confirmed and corroborated, and that's when I realized that medicine was my path and what I wanted to do.
Very exciting. Well, it's interesting. Okay, so you love medicine, but at the same time, you didn't really deviate too far from engineering because you decided to reconstruct people. You decided to pursue surgery. Tell us about that. What prompted that? Is that your attempt to stay connected to the family tradition?
I never thought of. This is the first time anybody makes me realize that. But and particularly cardiac surgery. When I'm explaining an operation to a patient, I always ask them if they're what they do and what their job is, and the line of work, because talking to engineers really makes it a lot easier to explain how I'm going to repair a valve, how I'm going to replace a valve, and after all, the 4 valves of the heart are just check valves, right? So it is interesting, yes, and I guess the reason why I decided not to go into engineering is because I'm not very good at math. I'm pretty good with my hands, but you're right. I think the love of manual work and reconstructing and restructuring the heart has a lot to do with engineering. So it in the back of my mind must have been there, yeah.
And when we get to it, and in fact, some of the novel procedures you're doing essentially involve reconstructing, re-engineering, or reimagining how the heart is currently put together. So
Absolutely.
great. So after medical school, you decided to go abroad to pursue your studies. Tell us a little bit about that and why leave Colombia?
So that came from the fact that I even though Colombian medicine was very good and the medical school experience was superb in the sense that you had a lot of hands-on experience, I thought that it was lacking in science, mostly because of lack of resources, and my thought was that if I wanted to really exert a change and have an impact on medicine for the country, I had to go abroad and train in one of the top 10 institutions in the United States, and I was truly influenced by Tom Shires, who was at Cornell University at the time.
It's my chair.
Yeah, there you go. And I used to, because of work and business, my parents used to go to New York quite a bit, and I would go with them and try to get an interview with Tom Shires. I would talk to him. I was fascinated by him because I had his textbook, the big
course.
yellow textbook.
Surgery.
Exactly.
Principle, yeah.
And the principles of general surgery and the principles of surgery. And when I finally was able, after sitting in his office for hours waiting for him to come out, he finally came out and agreed to talk to me, and that was one of the most enlightening conversations I ever had. And
What year was that, by the way?
that was 19 must have been 1981,
Okay.
1980. But there was uh no, I'm sorry, no,
A
19
little later.
later. It was 1984. So I was a medical student back then
Okay.
in Colombia, and he gave me hope.
Yeah, that's great.
And I figured I could actually make it into one of those top 10 programs. And specifically, I was looking at Cornell, I was looking at Columbia, I was looking at Stanford, I was looking at Mass General, and of course, for a Colombian medical student to be thinking of that was a little bit, most people thought I was out of my mind.
I may have run into you on F7. That was the floor at New York Hospital because I was a resident. Good. Okay. All right. So, but you went to Europe. You went to.
So in order to get here, I figured I had to boost my CV, and for that I decided to go and do research in the field that I wanted to go into, which is liver transplantation. I wasn't planning on being a cardiac surgeon, and I got a position at Queen Elizabeth Hospital in Birmingham, England, which was the mining capital of the UK.
Sure.
Gray, dark, rainy. Imagine Colombian in that city. It was quite an experience. But it turned out to be a wonderful experience. And being there, I applied to several general surgery programs in the U.S. and I guess my entire career in surgery has been defined by serendipity in a way, because I ended up interviewing at Columbia University, where the program coordinator happened to be Colombian, and she for some reason liked me, and when I interviewed with one of the program co-directors, who was this young general surgeon, John Chabot, was a liver and pancreatic surgeon, which is right up my alley. The other one was Peter Altman, whom you probably know.
Of course, for pediatric surgery.
Exactly.
Yeah.
Exactly. And when I interviewed with John Chabot, one of the things he asked me is, well, what will you do if you don't get accepted? And I said, well, I'll go back to Colombia and plant potatoes. And he said, come on, right? Seriously. We're sitting just like this, and I said, no, seriously. And he goes, but you're willing to throw away, all these years of studies and things and effort? And I said, yeah, it's been wonderful, but my second great love, if not general surgery or surgery, is farming, and I'd go back to that in a second. I still think about that, by the way. That maybe is a retirement plan, but one thing led to another, and I ended up getting a preliminary position at Columbia University, which I took in a second. And again, serendipitously, one of the preliminary interns, who was going to maxillofacial surgery, decided he was going to do ENT, so that spot was open. And he and I became very good friends afterwards, when he was an ENT surgeon, and I got in there, and of course, being a preliminary resident, coming from Colombia, at Columbia University, I was matching up, or trying to match these Harvard graduates, Columbia, AOA individuals. Some of them had even Wall Street experience before going into medicine. So I was the odd one out, and that just meant I had to get to work at 4:30 in the morning and leave at 8 o'clock at night. So basically, get there an hour before everybody got there and leave 2 hours after everybody had left. And That's when I met Mehmet Oz, who was a young attending. He had just come back from a traveling fellowship, and he was doing the same thing. He'd get there not 4:30, but he'd get there at 5:15, and he was surprised by this guy who was always sitting there when he got there. Until about 3 days into it, he turns around, stops at the desk where I'm working, and goes, "Who the hell are you?" And I said, I told him, and he said, and are you going to be going to cardiac surgery? And I said, no, I think cardiac surgery is extremely boring. He said, what? What? Yeah, cabbages, valves. I like liver transplantation. That is
real surgery. Yeah.
And then the conversation every morning was, "Hey, good morning. Are you thinking about it?" Yes. and, and of course, during my second year, I ended up having spending some time in the CVICU, and a couple of experiences there made me realize
you had to operate with him, or take care of some of his patients.
I took care of some of his patients, operate with him. Go into the OR and be a second assist,
doing some veins.
Well, it was actually mitral valve surgery.
Okay.
And he went to a meeting in Italy, in Bologna, and there he met Ottavio Alfieri, who was this pioneering mitral valve surgeon, who had described a technique to repair the mitral valve that was basically heresy to any of the established mitral valve surgeons applying the Carpentier method, because he was taking the leaflets of the mitral valve and sewing them in the middle, right in the middle of the valve, these leaflets that would prolapse. He'd take a stitch and just sew them together in the center. So you ended up with a valve that looked like a butterfly, like a bow tie.
Yeah.
It's a bow tie mitral valve repair, as a matter of fact. And Mehmet came back when I was rotating through the unit, and said to me, he said, "I'm going to try this." And we did the first patient in the middle of the night, patient with an acute MI, who had a rupture of his mitral valve, and we repaired it that way. We repaired the papillary muscle, of course, and did an edge-to-edge repair, and then from there we carried on to other cases and published the first report, which we coined as a bow tie repair, because of the appearance on echo in 1997, the Annals of Thoracic Surgery, and that got me hooked, and I presented a project to go into his lab, and the project involved comparing the bow tie repair to the edge-to-edge repair, as it's known today, to a conventional annuloplasty.
Okay.
And when we were discussing the findings of those studies, which were animal studies, at one of our morning research meetings, after everybody left, Mehmet comes up to me and goes, "Do you think we can do that without stopping the heart? Don't you think we should be able to put a clip in there, or a clasp or something?" And that got us working with my biomedical engineers.
There you go.
Absolutely
Back to
fascinating.
your roots.
So it takes me right back to it. I hadn't realized this. You just made me realize it. And that was absolutely fascinating, working with biomedical engineers and coming up with a way to do this, to do the edge-to-edge repair, without having to stop the heart. And we went through multiple iterations. Of course, what we wanted to do was do it in a way that only surgeons could do it, but obviously the logical way was a transcatheter approach, as it is known today as the MitraClip or the TEER, and that's how we got to the patent of the MitraClip.
So that turns the valve into a bow tie, essentially.
Exactly.
Okay.
Exactly.
And good functionality, great outcomes.
Well, yeah, I was looking at the numbers recently, and when you look at the growth of TEER or transcatheter mitral valve repair, it went from 0.6 per 100,000 Medicare beneficiaries to 17.6.
Wow.
Whereas, yeah, and that's over the last 6 or 7 years alone. So it's growing tremendously. The thing is, you have to be very careful which patients you use it on. And when you have a mitral valve repair center of excellence as we do, really the standard of care, the gold standard for mitral valve regurgitation is a minimum invasive mitral valve repair, as we've been doing here. Only patients that are extremely high risk or not surgical candidates should have a transcatheter repair. And now the reason for that growth is that really mitral valve repair is not done as often and as well as it should be. And that's what sets us apart here as well, which we can talk about.
You health, yeah. We dream, and as your fellow surgeon, we or physician, we always dream of having an impact. Now, how does it feel to have something you help discover, or a process, a procedure you help establish, impacting lives in such a positive way? How does that make you feel?
I never actually stop and think about that. But it is I feel very proud, but more than proud, I feel extremely lucky to have met somebody like Mehmet Oz, that was able to, first of all, change my whole trajectory, and get me to think that much outside of the box. And I think that is what we as educators have to do. And it's not easy.
Without question, but you're really speaking to the power of mentorship, first of all, stimulation of curiosity, the creativity to come up with a new approach, but also the tenacity to keep meeting with all of these other engineers to come up with the right approach to do this. That is the formula for being impactful and making really innovative changes in medicine.
Yeah, no question. And it's a once in a lifetime thing. And I think that finding a way to replicate it is really the holy grail. But that's I think exactly what brought me here.
And to a large extent, that's what you're doing. Let me fast forward a little bit. Now you've already had this major discovery, innovation in your, I guess, portfolio, and but you decide after you went from Colombia, you went to Stanford, another premier program in cardiothoracic surgery, and then after that, you decided to go to Colombia. After all this training and the signature invention, back to Colombia. Were you thinking about going back to that farm? And tell us about it.
No, I at that point, what I wanted to do was take advantage of all the knowledge I had gathered, and that how lucky I had been, and try to give back to that country that really had given me everything.
That major.
Yeah. And in a way, not a way, but really trying to leave a legacy behind, in the sense of training, mentoring of surgeons, and elevating the level of cardiovascular medicine, cardiac surgery, for a country that I thought had all the potential, but had always lagged behind countries like Brazil and Argentina, which were very predominant in Latin America. And the only reason why I was able to do it and go back was because I had an institution that was equally open-minded, and willing to take that chance of building a truly unique, lasting, modern program. Yeah. Okay.
Because I imagine you have all the sophisticated tools. You came into place, what I call the FAO Schwartz of cardiac surgery. You had all the things you could, and then you had to essentially establish a sophisticated program in Colombia from scratch.
Yes.
Without resource. How'd you do it?
It involved everything from negotiating with providers, and having the knowledge and the background and the recognition in the U.S. helped tremendously, because then all of a sudden companies that have not had any presence in Colombia or Latin America were interested in going to Colombia. And the backup from the institution to make sure that we could actually make that come true, and become a reality. And again, serendipitously, I had worked with people in the industry because of the mitral clip, amongst other things. And these people actually bet on me to provide us with the devices that we needed, at least to get started. And at that particular point in time, Colombia was going through a very good moment with a president that was very firm with the guerrillas and violence and things, and the healthcare system was actually very, very, very well established and functioning tremendously well with very limited resources. But that's what made it even more exciting, because we had to come up with ways of doing the same, level of sophistication, or maintaining the levels of sophistication that we had in the U.S. without the resources. So do it as well as here, only cheaper. And that became actually my
Mantra.
Yeah, that is exactly right.
That's exciting. So obviously, because of your sheer tenacity, vision, determination, energy, you transformed cardiovascular medicine in Colombia.
Well, I'm not sure I did, but I
know you understated.
I was
You were a catalyst for change.
I think I was. And of course the talent was there, and fortunately we're able to overcome envy, which is one of the most destructive forces ever, as I'm sure you're aware and you've encountered. But I was able to bring people together and share that vision in different cities simultaneously, and promote training, and basically breed a new generation of surgeons that, again, through my connections with the U.S. and Europe at that point, we're able to start sending Colombian surgeons out to Europe and the U.S., get trained, and come back or go back and continue that legacy.
This is really what I call visionary servant leadership, because you brought disparate groups together who were probably quarreling, were probably competing, but made them understand that truly we achieve our best together, and you were serving as a mentor, a unifier, and everything else. So that's truly remarkable. So now you built this essential empire down there. Then what led you to leave after nearly 2 decades?
I reached got to a steady state where I felt that things were running as I had envisioned them, at the institution where I was at, as well as a country. And you can choose to stay and in a way become stagnant because that,
you already achieved the maximum that you could deliver.
yes, and without the, at that point, resources drag you down. I don't know if that is the right word, but two things came together. One is that I had achieved what I wanted to achieve, but more importantly, my succession plan was in place, and
Excellent.
and for them to grow and realize their full potential,
You had to leave.
I had to leave.
You had to step aside, which is, again, a great mark of leadership, knowing when it's time to move on, for the next generation to take over. Well, this is great. So it's our game, obviously, our game, because then you came to Cleveland, in Cleveland Clinic, and then we were able to recruit you to the University of Miami Middle School of Medicine, and you helped. So tell us, what attracted you to us?
The culture, and the possibility of moving into an academic institution, the only academic institution in South Florida, and one that has an enormous potential to impact now not only South Florida and Southeast, but all the Caribbean, Latin America, at a much larger scale than what what I was able to achieve in Colombia. And I felt that with the current leadership uh, of the School of Medicine as well as UHealth, I truly had the possibility of leading one last mark, and taking an institution like this to the next level, or helping get UHealth and the University of Miami to the next level in cardiothoracic surgery and cardiothoracic medicine.
Obviously, I'm very excited about it. We're excited to have you and feel privileged. And so tell us a little bit. You've only been with us on that for like 5-6 months. Yeah, not even. Yeah. But we can, the changes that you've implemented are truly palpable. Tell us about your vision for the Department of Cardiothoracic Surgery, and why patients should come to you help for their cardiac care.
Well, again, I think the University of Miami, being the only academic institution, is called to be the reference center for complex cardiac surgery and cardiovascular medicine, imaging, as well as medical treatment, but surgical treatment very important. And we have absolutely everything we need to do that. What we're establishing is a truly multidisciplinary team that is patient-centric. One of the things, one of the quotes that impacted me tremendously, throughout my life was Steve Jobs in his biography, describing his care for his cancer, for his pancreatic cancer, and saying that what he was seeing at Stanford back then was exactly what he didn't allow at Apple, which was outstanding yet fragmented care. So the first thing that we're doing as a team is making sure that we break down silos and bring every single specialty and subspecialist together around the patient, so that the patient is not torn in multiple different directions, but instead is cocooned by a team of specialists and nurses, and that are whose only purpose is to make their life better, quality of life better, restore their life expectancy, and cure them of their disease. And again, we have everything to do that, and that's what we're doing. The second thing is of course training the next generation of cardiac surgeons. I think that is a great responsibility, and one that we are working very hard on, making sure that the top medical students and residents want to come to UM, and that we train them in such a way that again, in a few years, I can step back and say, okay, my work is done. I think that is the only true legacy we leave behind, and I'm sure you agree with that. Otherwise, in your position, you must. It's what drives us.
Without question, this is a tremendous. We have a tremendous sense of social responsibility to groom the next generation of physician scientists. Now, from your position as we close, tell us a little bit about where you see cardiovascular medicine headed, and the role that you and your department will play in shaping innovation and creating the best opportunities for the citizens of South Florida and beyond, in Latin America, since we stand at the gateway of Latin America and the Caribbean.
I think that if we stay on that heart team theme, the future of cardiovascular medicine is at the intersection of medical, interventional, and surgical specialties. I think open surgery is going to be a thing of the past sooner than we think, and transcatheter therapies are going to be taking over, but not by themselves. I think it's going to be somewhere in between, and that's what we're establishing: a hybrid team of specialists that can take care of whatever needs to be taken care of minimally invasively, or even open, to then complete the operation in a hybrid fashion, transcatheter fashion, because it's all about offering patients the right treatment at the right time through the right approach, in order
right team.
by the right team, and all that to make sure that we are restoring life expectancy and quality of life, uh, while at the same time making sure that we minimize pain, disability, and all the rest.
Dr. Umaña, what an amazing vision. What an amazing life story. And you're still young. We are thrilled to have you as the head of cardiothoracic surgery. But more importantly, it's what you bring to the table. It's your vision, your passion, your ingenuity, and your commitment to training the next generation. And we're truly fortunate. And for our citizens in South Florida, wow, what a great opportunity to have such a visionary take care of them. So welcome to the family, and we look forward to your many fascinating contributions.
Thank you very much, Dean Ford. It's a pleasure and an honor to be here. Thank you.
And this has been another episode of Inside Umami Medicine with the amazing Dr. Umaña. Join us for another episode next time.